inviting me to speak today. So this talk actually follows Professor Durham's lecture, I think, pretty well, in that it's sort of a little bit of an expansion on, in fact, the last questions, which is talking a little bit about asthma prevention and talking a little bit about safety, especially with the focus on subcutaneous immunotherapy. The last lecture, of course, was really focusing on sublingual immunotherapy. Now, I know that in the region, subcutaneous immunotherapy isn't as common, but I also know that there is a process in place to try to get more subcutaneous immunotherapy products in the local market, and I think that's an important option for us, because while sublingual immunotherapy is really an exciting treatment option now for our patients with allergic rhinitis and some with allergic asthma, there's also patients that would prefer the idea of a less frequent treatment, a once monthly injection, for example, than a daily treatment. Some of the patients that I counsel as an allergist immunologist on the option of immunotherapy balk at the idea of having to take the tablet every day. Part of the attraction of immunotherapy is the idea of having to take less medication for their condition. And so if we're replacing one medicine with another daily treatment, especially when we say, and by the way, this treatment is going to take 3 years to have its effect, that sometimes is a bit daunting. So what I'm going to do is because Dr. Durham or Professor Durham already spoke about a lot of these things, I'm going to speak briefly about some of the mechanisms of immunotherapy, which were brought up in the question period as well. And then I'm going to talk a little bit about some novel approaches with allergen immunotherapy for asthma. So not just symptomatic treatment, but disease prevention or modifying treatments. And then I want to spend a few minutes talking about the risks, especially, again, focusing on subcutaneous immunotherapy, which really does carry a significantly greater potential for adverse effects compared to sublingual. I always like to at least frame the discussion with a couple of cases. So these are just ones to think about in your mind. And I think this one also flows nicely from the questions during the last discussion period. So a 6-year-old girl with mild allergic rhinitis. The mother has asthma and allergic rhinitis. The child has no current symptoms of asthma or food allergy, and she's monosensitized to dust mite, which again, as has been mentioned already a number of times this afternoon, is very common here in this region. I come from the prairies of Western Canada where nobody was allergic to dust mite because it's too cold and dry even for dust mites. And then I come here and everybody I see is allergic to dust mites. Her symptoms are fairly mild and well controlled with intermittent intranasal steroids and second-generation antihistamines. So the question I want you to ponder is, would you be thinking about allergen immunotherapy for this patient, and what would be the rationale in somebody with relatively mild symptoms and good symptomatic control? The second case to think about is her mother. So she's got asthma as well as allergic rhinitis. They have no pets at home. She's a non-smoker, and her asthma is stable and well controlled, but with moderate dose combination therapy. She's had no exacerbations recently, no need for oral corticosteroids. Her lung function is within normal limits. She's got some allergic rhinitis. It's also well controlled with regular intranasal steroids, and she's polysensitized. She's also allergic to birch, which she developed living elsewhere, and as well as cats and dust mites. And again, is she a good candidate with moderate persistent asthma, or well-controlled at least persistent asthma? So I'm not going to spend a huge amount of time talking about the background, but again, a lot of the lectures in a symposium like this focus on really new treatments like the biologicals. This is a really old treatment. This is the oldest treatment we've got for allergic disorders. It's one of the oldest studied treatments that is still in use in medicine, and has had its century anniversary many years ago already now. There's very clear evidence for the benefit of subcutaneous immunotherapy in allergic rhinitis and venom hypersensitivity. And there's also strong evidence for its use in allergic asthma, and some of which is inferred from its benefits on allergic rhinitis. What we know with immunotherapy is that after successful immunotherapy, patients have less release of inflammatory mediators when they're challenged with the allergen for which they were treated. And we do see very clear and predictable responses in antibody responses. Usually there's an initial rise with immunotherapy. We see this with sublingual, subcutaneous, and oral immunotherapy for food allergy. and then eventually a decline in specific IgE that tends to correspond with a rise in IgG, and as Professor Durham was mentioning, IgA with sublingual immunotherapy. And we see an induction of regulatory B cells. We also see profound changes in T cells as well, including the induction of regulatory T cells and suppression of antigen-specific T cell proliferation. Again, we see this shift in the immune response back away from the Th2 cytokine profile with successful immunotherapy. Now, subcutaneous immunotherapy, which is really what I'm going to focus on again, we now, after over a century of regular use, we only recently have identified optimal doses and well-characterized or standardized allergen extracts. Certainly for allergic rhinitis and for venom immunotherapy, stinging insects, wasps, hornets, etc., we now know very clearly what doses are effective in both protecting and minimizing symptoms and making long-term immunologic changes. It does require regular clinic visits, initially weekly to build up, and then monthly maintenance again. And the treatment duration is similar with what Professor Durham was mentioning. 3 years is the standard treatment course. Local reactions to the injections are very common, but it's really important to know with immunotherapy, with subcutaneous immunotherapy, that there is a significant risk of a systemic reaction, as high as 1 in 6 in some studies. It's not an insignificant risk, especially with properly dosed immunotherapy. A lot of previous immunotherapy was fairly low dose, probably inadequate dosing for many patients, and then was much safer, but was really not effective. And again, the immunologic effects are maintained for many years. Some studies with subcutaneous immunotherapy show up to 7 to 12 years of continued benefit. I'm not going to spend any time talking about this, but this is the group of allergens for which we currently have standardized extracts and clearly established, published, evidence-based data on the effective optimal dosing. There's many other allergens that are commonly in use that aren't on this list. I tend not to make use of most of those allergens. And there's some that are emerging, like birch pollen is now coming out in a standardized form as well. I'm not going to really spend any time talking about sublingual immunotherapy because Professor Durham did such an excellent job there. I want to spend some time just talking about the role of immunotherapy with asthma specifically. And as everybody knows here, asthma is a multifactorial disease. Allergy may or may not be a significant contributor for the patient you're seeing in front of you. There's many other factors like irritants, like the dust storms we've had. Infections are still the #1 cause of asthma exacerbations in all age groups, regardless of atopic status. And of course, a lot of other factors, including psychosocial stresses. Allergen immunotherapy, again, really only targets that one specific allergen, or if you're doing multiple allergens, but it doesn't treat these other parts of asthma. So again, it always has to be looked at as part of a treatment. It's not just a silver bullet that's going to turn off somebody's asthma overnight. And there really has to be clear evidence of clinical allergy. This goes back to David's talk earlier. Sensitization alone is not sufficient to confirm clinical allergy. There really does need to be a convincing clinical history. With some allergens, that's easy. Seasonal allergies, it's very easy to tell if there's a relevant clinical history. With furred animals, usually it can be based on symptoms with exposure. A lot of people will deny symptoms with their own pets, but they may admit to having symptoms with other pets, which means theirs is a relevant exposure. Dust mite is trickier, but if somebody has chronic persistent symptoms that are consistent with IgE-mediated disease, especially if they have concurrent rhinitis to go along with their asthma, and they're sensitized to dust mites in a place where dust mite is endemic, again, not where I'm from, but practicing here, I think then that's now a stronger case. And in fact, what we know is that dust mite, as just a specific allergen, has a very important role in driving the inflammation with asthma. Patients with asthma who have not yet been sensitized to dust mites still have problems with exposure on the long term. And that exposure increases the risk of sensitization over time. There's a dose response exposure curve with dust mite allergen in atopic individuals. And that sensitization then increases asthma severity. It's a risk factor for recurrent exacerbations. And in the newest guidelines focusing on the role of immunotherapy, the strong suggestion is that in patients with confirmed dust mite allergy, if an adequate trial of dust mite avoidance or mitigation has not made a significant clinical difference, then they should be considered a potential candidate for immunotherapy. Again, I'm not going to go into great detail here. There have been a lot of clinical trials looking at the role of immunotherapy with asthma for many, many years. Many of them are flawed. A lot of them are trials that if we could sort of start again at scratch, we wouldn't do them the same way. This is one of the reasons why a lot of the clinical study data on sublingual immunotherapy is simply superior to the data for subcutaneous. It's because being a newer treatment, it had to go through a much more rigorous clinical trial program to reach approval, where subcutaneous, again, being over 100 years old, had much more flawed data along the way, unfortunately. But what we do know is that when we look at the meta-analyses of sublingual or subcutaneous immunotherapy trials, the benefit in asthma seems to be comparable to low to moderate dose inhaled corticosteroids. And that if you treat 3 patients with allergen immunotherapy, you can prevent a clinical deterioration, not necessarily a severe exacerbation, but a clinical worsening of their asthma in 1. If you treat 4 patients, you can avoid an increase in treatment in 1, which is not bad numbers, frankly. You improve bronchial hyperresponsiveness. There's no consistent impact on lung function, and Professor Durham didn't mention lung function either, as you'll notice. There's not a lot of good clinical trial data on exacerbations. It's interesting, as Professor Durham mentioned, the recent German data that shows a long-term protective effect on exacerbations. And beyond that, there hasn't been much good evidence on the prevention of exacerbations specifically with immunotherapy. And you get 1 systemic reaction for every 9 patients treated with subcutaneous immunotherapy, again in the meta-analyses. This really is a shared decision-making process, and I'm going to come back to shared decision-making when we go back to our cases as well. We should be considering immunotherapy for patients with mild to moderate asthma who place a high value on relatively small improvements in quality of life and symptom control, or a high value on decreases in long-term or quick relief medication use. Those also should have a lower value on the potential for systemic reactions. So the patients who say, "Doc, I want to do everything I can to need less medicine," or a little improvement in my quality of life would go a long way for me. That's the kind of patient where immunotherapy is, for asthma specifically, is very attractive. So these are the kind of values that we need to consider when we're sitting down with those patients. So now I want to shift gears and talk just a little bit about a couple of specific scenarios. So while we know that it can have an impact on asthma symptoms and medication use, one thing that hasn't yet been well studied is its role in helping patients step down therapy to facilitate an intentional dose reduction. So it's one thing to say once a patient's treated, they often need less medicine. But in somebody who requires a moderate to high dose of inhaled steroids or maybe multiple preventative therapies, can immunotherapy be used to facilitate a dose reduction? There's not a lot of studies that look at this, but in a small number of studies, what we do see is that, for example, one adult study, a 90% reduction in inhaled steroid dose after 2 years of subcutaneous immunotherapy. In the moderate asthmatics, it was much less pronounced in the mild asthmatics, which again, is what Dr. Durham mentioned. One pediatric study showed about a 50% dose reduction, and that may be very significant for some families who have a degree of steroid phobia, who again want to make every effort they can to minimize the treatment for their child. The benefit definitely seems to be greater in moderate versus mild asthmatics. And again, this goes back to the discussion period, how much of that is because of the effect on concurrent allergic rhinitis. We have to remember that a huge majority of our patients with allergic asthma have allergic rhinitis. Often it's either underappreciated or undertreated, and allergic or subcutaneous or sublingual immunotherapy will treat both. So again, at the very least, they may get a significant benefit with their allergic rhinitis. We know that comorbid rhinitis or rhinosinusitis not only can help influence asthma severity, but is a predictor of failing step-down therapy. So then to the other important question that was brought up, what about the potential for using allergen immunotherapy to prevent the development of asthma? Right now, when I see very atopic young children, I might say to the family, you know, they've got about a 40% risk of developing asthma. They've got food allergies, they've got atopic eczema. And the family says, well, what can we do to prevent that? And really, currently, not much. But allergen immunotherapy is an exciting potential option here. We know that allergic rhinitis is a major risk factor for developing allergic asthma. We also know that there's a dose response there. The more severe the allergic rhinitis is, the earlier it manifests, the greater the risk of developing asthma. We also know that in children with one allergy, if they develop new allergies over time, that it further increases the risk of developing asthma. Again, a dose response with the number of allergies you have. And so we now know that from one meta-analysis, a systemic review, 3 years of allergen immunotherapy decreases the risk of developing asthma by around 40%, which is not an insignificant amount. And this really, again, is mostly in children. And so again, looking at this graphic, you can see, looking at the number of studies, very small, still small numbers of patients. We absolutely need more data in this regard. And as a pediatrician, this has not necessarily led me yet to do this routinely in my atopic patients, but the data is growing. Over the past 20 years, we've seen that the number of studies go from one very small study now up to 5, and I'm hoping we're going to see this data be replicated more and more. Less convincing data on the development of new sensitization. So that's another thing you'll hear, is that early treatment with immunotherapy in a monosensitized individual may decrease the risk of developing new allergies. Again, the data are there, but they're not overwhelming. And so again, if you look at this graphic, and I don't know if well, I guess the pointer doesn't really work on this kind of screen, but what we see is that traditionally we would be looking at allergic rhinitis, again, as was mentioned earlier, in patients who have inadequate control despite optimal medical therapy and optimal allergen avoidance. So the farther right side of this graphic. But we maybe need to be looking more on this left side, which is the patients who are at higher risk when their immune system is still pliable and maybe amenable to disease modification. And so in the patients who either have very early allergic rhinitis or even before they've developed clinical symptoms, if they have a number of other risk factors. And again, I'm going to say right now, I don't do this routinely yet because I don't think we have enough data, but I do think that this is where we are heading. And as more data emerges, I think this is going to become a more important option. So I want to talk the last couple of moments about safety. Again, local reactions at the injection site, redness, swelling, itching, are incredibly common. If they're not happening, you're probably not treating with the right allergen or the right dose. Local reactions, however, do not predict systemic reactions. They don't need any specific dose adjustment unless the local reaction is proving to be a barrier to successful treatment and adherence. But we now know that systemic reactions aren't predicted by local reactions. But systemic reactions are well described and can be very much severe. Life-threatening or fatal anaphylaxis is rare. You can see from the numbers there, we're not talking about high numbers, but when you talk about the number of people receiving immunotherapy, it happens. We know that systemic reactions of the mild variety seem to be fairly common in children, even more so than in adults. Luckily, severe reactions are relatively uncommon in both. But if you look at the next line, what you see is that while severe fatal reactions, I should say, are incredibly rare, there does seem to be a trend, not statistically significant, but small numbers, a trend towards an increase in that. If you look from 2008 to 2014, there were 2 confirmed SCIT fatalities, and then from 2015 to 2017, another 5. I wonder if some of that has to do with an increase in the potency of the allergens, understanding optimal dosing better, optimizing the therapy more, but in a way then that is more likely to cause a severe reaction. I also wonder if it has to do with a bit of that expanse into treating more asthmatic patients potentially as well. Most reactions develop within the first 30 minutes, and that's why a mandatory observation period with subcutaneous immunotherapy is non-negotiable. If patients won't stay in your clinic for 30 minutes after, you should not be treating them with immunotherapy. If patients have had a significant systemic reaction, it makes sense to prescribe them an epinephrine autoinjector to keep with them, but it is no longer recommended to do that routinely as a precaution in patients receiving immunotherapy. Again, immunotherapy injections need to be performed in a clinic prepared to recognize and treat anaphylaxis. And patients who do have asthma need to be screened to make sure their asthma is stable, hopefully well controlled before receiving an immunotherapy injection. It should be postponed if they have uncontrolled asthma, fever, or any significant respiratory infection. And we have to be careful with the well-known cofactors of anaphylaxis, things like vigorous exertion shortly after receiving their injection, increased body temperature, such as hot tubs or saunas, or alcohol use. So just to close then, I'm going to just finish back at the two cases that I mentioned before. So a 6-year-old girl with mild allergic rhinitis, well controlled with intermittent therapy. Is she a good candidate for allergen immunotherapy? Again, it's complicated. I'm not going to say that I take all of my 6-year-olds with allergic rhinitis and put them on immunotherapy. I don't. I actually do, frankly, as an allergist, relatively little immunotherapy overall for a variety of reasons. However, again, as the data is emerging here, we have to think about her risk for asthma. Her mom's got asthma already, so we know there's the immediate family history. We know she's already sensitized to an allergen strongly associated with asthma risk. And again, this is shared decision-making. If the family says, we want to do everything we can do to make sure she doesn't follow in this case, the mom's footsteps, then immunotherapy is an option to discuss, whether sublingual or subcutaneous, at this age probably sublingual, but as a potential disease-modifying option at this young age. And for the mom, again, well-controlled asthma, allergic rhinitis, polysensitized, but living here where dust mite predominates, she's probably not going to get a lot of symptomatic benefit from allergen immunotherapy. She's already well controlled. She's doing well. Her lung function's good. She's not having a lot of symptoms. However, for her, the option would be, could we use immunotherapy to help facilitate a dose reduction? Now, I would argue before immunotherapy, you'd try to reduce her dose to begin with because she's already stable and she hasn't had recent exacerbations. Her lung function is good. But if that is unsuccessful, again, shared decision-making, we can have the discussion about long-term benefits and the potential to facilitate a medication reduction. So with that, I'm just going to close by, we highlighted the immunomodulatory disease-modifying effects. It can have impact on asthma symptoms, medication requirements, bronchial hyperresponsiveness, less convincing data on exacerbation rates, and the potential to facilitate step-down therapy, the potential to decrease the risk for asthma development, but again, with subcutaneous immunotherapy carrying a risk of systemic reactions. Shared decision-making, I think, is a good take-home message for this session. Thank you.
Thank you very much.